Good morning, everybody. Thank you for the introduction. So I'm here to talk about what should be considered in patient safety. The learning objectives are to appreciate the core competencies of the radiographer in a way to ensure patient safety in the radiology department, to learn about patient safety concepts that involve all the theory around it, and to discuss ways to promote patient safety, mainly at the radiological department. I start with this Latin axiom, primum non nocere. It's attributed to Hippocrates, and we should all keep it in mind because when we receive a patient, the patient is somebody that needs close attention. He wants to relieve his pain or to get cured from a disease. And the first thing we should do or not do is to harm the patient. I bring some statistics about patient safety. Kohn et al. Said that between 44,000 and 98,000 diseases are caused by patient safety issues, not the underlying condition of the patient, and more than 1 million are injured during the healthcare process. Medical errors are the eighth most important cause of death in the United States, so it's quite alarming this, because this is not the underlying disease of the patient, this is the healthcare. I should not say this, but somehow kill the patient. Preventable harm can result in severe disability in 1 in 10 patients admitted to the hospital, and 1 in 3,000 might even die due to our job. Damage due to intervention of healthcare happens too frequently, and most of it is preventable. In a big study developed by Sanders and Cook, they reviewed 13,000 records from patients in New York State, in 51 hospitals of New York State, and they verified that the percentage of admissions that resulted in adverse event was 3.7%, so it's quite a lot. And the proportion of adverse events that could have been prevented was 58%. So basically, half of this could have been highly preventable. Another statistics, in a research carried out in intensive care units, 2.9% of the admissions resulted in adverse events, and also half of this is avoidable. Another research, 10 adverse events by 100 admissions. 65% of these cases did not harm the patient, 30% harmed the patient, and 5% were severe damage, including death, and half of this could have been avoided. So why does healthcare makes this to patients? This is not supposed to happen. Basically, this is another Latin axiom, errare humanum est. Basically, it's an axiom attributed to Seneca that says that all human will make a mistake somewhere in the role during the work. It will happen. It surely happened to all of us, professionals. Basically, each person performing one task will, at some point of that task, commit a mistake. This will happen. Despite we do that task very often, we will make a mistake sometime. And errors can occur before our intervention, during our intervention, and after our intervention. This is important to know because the error acts like a chain. We are just a link on that big chain. for example, a patient that was not identified properly before arrive our department, we will x-ray the wrong patient, then the doctor will see the wrong image, then, well, this is a chain. And I present you one famous model in patient safety. This is the Swiss cheese model created by James Reason. Basically, each cheese slice with the holes, typical from the Swiss cheese, are barriers that will prevent harm to occur in the patient. We should also look at these slices as always moving. The error will happen when one hole in each slice is aligned. So each slice, each protection that protects the error or other safety problem from the patient, when each protection has a flaw and the flaw gets aligned, the patient is harmed. What about the error? The error, basically, is a deviation of a result from a pre-established plan or the use of a wrong plan to achieve a goal. This is the error itself. And the error supposes that there was a plan and the error was involuntary. So who makes an error doesn't want to make that error. Also, in the error theory, it's possible to err actively, or by commission, or passively, or by omission. These are definitions. Lapses or flaws are considered automatic and due to the lack of agility or attention of the professional, most of them, and mistakes are errors due to poor planning, poor use of the rules, or poor rationale of the professional. Most of us doesn't want to err. I should say none of us want to err. When we make a mistake in our job, we call it honest error. Basically, the honest error is or happens when a person that follows the rule, follows the protocols, follows everything that should be done, still make a mistake. This is an honest error. Of course, the professional has responsibility on that. He made it. But there is no liability possible on that error because it was not meant by the professional. This should be different from negligence cases. Of course, negligence cases also happen, but they are not errors. They are errors that occurred because the professional was not careful, disrespected the rules, didn't follow protocols, and of course, when negligence is proved, there is liability to the professional. About the radiographer role. Important safety breaches concerning developing, transitional, and developed countries were found in all the countries and in all departments. So it happens worldwide, not just in the Western world. It also happens everywhere. These breaches were divided in 3 quality domains in research developed by Jia et al. And the radiographers basically are present in all of these 3 domains. We have structural factors, basically organizational determinants and latent failures. We have structural accountability or the use of accreditation regulation to advance patient safety. We have the safety culture of the organization where we work. We can be committed by inadequate training and education or manpower issues. We can be stressed by, we can be under stress or fatigue during our work. Production pressures. Currently, it's a concern because healthcare governors want more production with less personnel. So this creates a patient safety issue that is very important. Of course, about CPD of the patient, the lack of appropriate knowledge, availability of knowledge, and transfer of knowledge. I should say that all healthcare institutions should give the professional the opportunity to access education, to access further developing, to access databases, to have reserved time for the patient to study, for example. But for my experience, that's not that common. And devices, procedures without human factors or engineering, of course, a device can also have a problem and damage the patient. About the processes, errors in process of care through misdiagnosis, errors of the process of care through poor test follow-up, to structure on process of care. We should, of course, in this falls the contrast issues. We should ensure that the contrast is in proper conditions to be administered, for example. The measures of patient safety that were adopted by the institution, for example, the identification of the patient with a bracelet, errors in process, for example, unsafe injection practices, the outcomes. So basically they are adverse events and injuries due to medical devices, to medications, to surgical errors. Of course, radiographers also work in the OR, so they are related to this domain. Associated infections, of course. We receive a lot of patients from different areas of the hospital, so we have a very important role in cross-infection or in prevent cross-infection. Unsafe blood products, pregnant women and newborns, concerns among older adults, false prevention, pressure sores and decubital ulcers. We should know that the patient has this before we receive the patient so that we don't aggravate the condition of the patient, and bring the patient voices to the patient safety agenda. This will be addressed later. Major concepts. It's important to have the major concepts defined because it's a way to generalize the knowledge and to share strategies. So an incident is an episode or situation that could have or did produce a needless damage to a patient. Can be as simple as a reportable circumstance, basically nothing happened to the patient, or a near miss, a no-harm incident, or a harmful incident. An incident type is a descriptive word for a class of format of groups of incidents with a common origin. For example, contrast incident, we can have that incident type or incidents related to contrast. A near miss is an error that could have caused physical or other type of damage to the patient, and it just didn't occur because the patient physiologically resisted to that error, or some other barrier prevented the error from affect the patient just in time, allowing the patient to recover from the accident trajectory and aborting that accident trajectory. The accident is an undesirable occurrence that affected the healthcare process and that compromised in a complete manner the final intended outcome, resulting in disturbances or major consequences that will be permanent to the patient. So the patient is harmed. An adverse event is an unintended damage that resulted in momentary or perpetual incapacity of the patient, disease or extended hospital stay, and is caused by healthcare process instead of primary disease. This is the definition. The adverse events are not mandatorily caused by errors or negligence attitudes, could be avoidable or unavoidable, depends on the adverse itself, and surely causes loss of efficiency of the radiology department and increase the monetary costs. We can divide the adverse events in major events. Typically, they occur during diagnostic or interventional procedure and threatens patient life immediately, imposing immediate life-saving actions. Usually, these events cause relevant physical damage. The minor events occur during diagnostic or interventional procedures, but unlike the major events, do not threaten patient's life immediately and directly. The most frequent minor events are called flux disturbances. For example, a phone ringing. The professional loses for a fraction of time the attention, but returns immediately to the job in a proper way. But the accumulation of these flux disturbances are shown to cause a major event. The never event is a serious, largely preventable patient safety incident that should not occur if the available preventive measures have been implemented by the healthcare provider. So this is a thing that really should not happen because there are evidence on how to prevent that, but the institution did not promote that evidence from being implemented. So it happened. It still happened. And this needs to a deep research from the organization to check the processes and the flaws on the process. And to be a never event, an incident must include the following criteria: have a strong probability or cause severe harm or death to the patient. There is proof of happening in the past, the same thing. Existing national and international recommendations to prevent this event from happening. And happening is easy to define, identify, and can be accessed continually. Danger. Danger is when there is a chance for potential adversity that propitiates the occurrence of adverse events with damage as the outcome. Danger could also be seen as an aggravating to the initial risk of a given procedure. Inherent risk is an unavoidable risk associated to a procedure, such as a given diagnostic or treatment procedure, that is prevented even when done in ideal conditions with the best equipment and the best team possible. So this is the inherent risk. It will happen. This is like the error theory that I've just talked a few minutes ago. Even with the best equipment and the best team, that error still happens. This is the inherent risk of a given procedure. The additional risk is what patients will be exposed besides the inherent risk when they are victims of safety errors or avoidable circumstances. As I also speak earlier, the error chain, an incident is usually a consequence of a sequence of errors involving the complex organizational causes. The only way to study these sequences is by root cause analysis. It's checking all the steps behind and check what happened in the chain, what was the link of the chain that first made the mistake. And, of course, safety culture, one of the domains that the radiographers should be in, and is defined as the product of individual and group values, attitudes, perceptions, competences, and patterns of behavior, shared by all the professionals in a given organization. So this is a culture. A culture is shared by everyone. It's a normal thing. So the safety culture should be the same thing. Should be at the end, it should create a safety environment. Safety culture, or the basics of this, should start to be taught at the initial formation of the healthcare professionals. So the schools have an important role in passing to the students the safety culture basics, to teach the students what is the error chain, the importance of them in that chain, and what could be done to prevent damage to patients, So this leads to the question, how can we increase patient safety in our departments? We can use, I have 3 suggestions. This is my first one and the most common one, the use of surveys. The use of surveys can access potential areas that are weak regarding patient safety. These areas are where errors can easily happen, and there are several measuring tools to assess the several dimensions of patient safety. Of course, we can create a better survey, but it's difficult to create a survey. And these surveys are usually made to the professionals. Of course, later I will talk about the patient side, but usually the surveys are made to professionals to check what professionals or how professionals act in a given situation. So we can access the areas that are weaker, and we can try or create ways to increase those areas in terms of safety. Much of these tools allow to assess the patient safety of an entire institution, or we can decide to apply it just to our department. Most of the researchers worldwide uses quantitative surveys. This is the best way to share easily information regarding safety culture, and at the same time propose changes in the patient safety by implementing interventions targeting several dimensions assessed in the surveys. Of course, most of the surveys are in English. Most of them are created in the United States, for example. If we want to apply a survey that was created in another language, surely we have to translate the questionnaire and we have to validate the questionnaire. Each one of these 2 steps that I've just mentioned have specific steps that must be taken into account to properly create our native language survey. And we can adapt that survey to our department, for example, eliminating parts or dimensions of the questionnaire that are not applied to our department, but it depends on the department or the institution goal. And I've worked with this questionnaire. It's one of the most broad questionnaires regarding patient safety. This is the Hospital Survey on Patient Safety Culture. It's created by an American organization. It's free to use. We can all look at the site of this agency and look what they have been developing. There are some validated surveys in other languages, for example, to Spanish, available, but there are some other languages that have been developed, but the surveys are not online on this website. And this instrument was increasingly used internationally with and without modifications, the adaptations that I've just referred to you about. About this questionnaire itself, it has the internal context of the department, so assessed by 7 dimensions: the teamwork within units, the supervisor role, the organization learning or the CPD of the professionals, the feedback on communication about error, the communication openness, the staffing, if they have much or less professionals as they need, and the non-punitive response to errors. It has the external context of the department or unit with 3 dimensions: the management support for patient safety, so this is at the organizational level, not at the department level, and the teamwork across units, because of course we receive patients from other units to our department, so this also must be accessed, and the handoffs and transitions if they have, for example, protected time. And it has 2 results dimensions: the overall frequencies of patient safety and the frequency of events reported, and 2 single items that are the patient safety grade or the opinion of the professional regarding the patient safety grade and the number of events reported. These are results of type 2, and these ones are results of type 1. And after we translate the questionnaire, the validation process will end with something like this, and we should look at the theoretical model of the survey. And as we see, this was the adaptation that I've made. The external context influences both the internal and each one of the result types, and the internal influence the result dimensions. So this is one way to assess patient safety and to increase patient safety, the use of surveys, to apply a survey, to check the current level of patient safety, to check the weak areas, and to develop work on those weak areas and increase patient safety on those areas. The other area is patient participation. This is not easy to do because professionals tend to work by themselves. The patient is not called in the healthcare process. It's just part of the healthcare process. But we should bring the patient to the process. We should, of course, we should explain all the time what we are doing. And this is important because the patient will understand if it's a repeated treatment, for example. If one day the patient arrives and the treatment is something in the treatment changed, the patient will notice, for example, and he will say, no, all the other times it was this way, so this time must be the same. And the professional, okay, oh, yes, I was about to do a mistake. And this happens very frequently. For example, we all ask the patient which arm has the best veins so that we can puncture the patient. So we should bring the patient to the healthcare process. We should overcome the paternalistic way of thinking of the healthcare professional. And of course, patients also need to be taught on this matter because most of the culture, patient will remain quiet during the procedure, will not ask nothing during the procedure. So this is a work that must be done. So they should be empowered during their diagnostic or treatment procedure. And in a big survey developed, the professionals believe that the hospitals should instruct patients in prevention of errors. This is important because it proved to increase decision-making in difficult situations, and the knowledge from other fields other than error, that patient participation is common, as shown to prevent errors. And the last option that I bring you is the use of expert panel to access weak areas or to check weak areas or which areas should be addressed in terms of patient safety. And basically this panel consists of specially constituted working group that meets for evaluation of a given subject. This is particularly complex particularly useful in complex subjects. Experts panel was used to identify the main problem of patient safety in the radiology department. We can use this just to the radiology department, and it's expected from the expert panel to produce outcomes of possible errors, formulates conclusions and recommendations on patient safety. And from this is the conclusions from an expert panel meeting. Take-home messages. Patient safety starts in each one of us. We are all links of a chain, a very complex chain, and we can start by access the patient safety levels of our department and work on the weak areas. Thank you.